before I start. Um, if you guys want to scan the code and get ready on Socrative, there'll be a few questions throughout the talk. So um, if you want to get that up on your phone, on your laptop while we wait, that would be ideal. And then we'll start in a minute or two. Okay, cool. I'm gonna get started just because there's quite a bit to get through, and then hopefully people can join as we're going along. So today we're gonna cover endocrine and renal, which are two quite big topics in LabMed. Usually quite a lot of questions on these two topics in the test. So hopefully we'll go through some of the most high yield stuff. That's most likely to come up on the formative and on the real thing. If at any point you guys have any questions, just pop it in the chat and we can, if we make good time, we can take a little break in the middle and I'll answer some of the questions in the chat. So let's get started. Okay, so we'll begin by covering endocrinology, which has four main points on the spec, which is endocrine biochemistry, adrenal neoplasia, thyroid disease, and thyroid neoplasia, and then glucose homeostasis. So we'll take this in four chunks. We'll start off with endocrine biochemistry. So this will kind of take you guys back a little bit to preclinical. So just to kind of set the scene, LabMed is a little bit more scientific than the AKT. AKT is very, very clinical, and you won't really have to pull on stuff that you knew in preclinical for the AKT. But LabMed still keeps some of those like core scientific concepts in the back of your mind. So it's good to review like things about the HPA axis, make sure you know your different pathways and the hormones that are involved. So just to do a quick recap of that, the general idea is that the hypothalamus releases a hormone that acts on the pituitary, which then releases another hormone that acts on a target organ to release the final hormone that then has the peripheral action. And then you usually have negative feedback both to the pituitary and to the hypothalamus. So there are basically these five main axes within the HPA axis that we need to know about and that are usually affected in pathology. So we're going to start off by talking about the adrenal cortex and the adrenal cortical axis. So that involves CRH being released from the hypothalamus, which acts on the pituitary to release ACTH, which then acts on the adrenal cortex to release cortisol. So in terms of these three, in terms of this axis, the three main pathologies that we need to know about are Cushing's, Addison's, and Conn's, which we're going to cover now. So, so to start, Cushing's syndrome, it basically just means excess serum cortisol. So this is the idea of like a syndrome. So a syndrome basically means a collection of symptoms. And Cushing's syndrome is the collection of symptoms you get when you have too much cortisol. Now, this can have different causes. Now, this is where you get the difference between Cushing's syndrome and Cushing's disease, where Cushing's disease is excess cortisol specifically because of a pituitary tumor releasing ACTH. Okay, so that's what Cushing's disease is. But you can get Cushing's syndrome because of loads of different causes. So you can get hyperplasia of the adrenal gland, so the adrenal gland just getting too big and releasing too much cortisol. You can get it as a paraneoplastic syndrome. This is actually tested quite a bit as well. So characteristically with small cell lung cancers, they cause a lot of paraneoplastic, so they can cause SIADH and they can cause Cushing's by releasing ACTH. Or if you just use steroids too much, your cortisol is going to go up because steroids are usually synthetic variants of cortisol. So you can get Cushing's syndrome a number of different ways, but Cushing's disease is specifically the release of ACTH from a pituitary adenoma. Now, let's kind of dip our toes into the questions by moving over to Socrative now. So if you guys have joined, you should be able to see a question up now that asks you a bit about um, Cushing's disease. So I'll give you guys a minute or two to answer that. Once you answer it, the answer will come up straight away. So have a read of the question, answer it, have a quick read of the explanation, and then we'll keep going and we'll have a quick chat about it. Okay, cool. So I can see most people dealt quite well with that question. So let's look at the pathophysiology behind what's actually going on. So I think it's really useful for these types of questions to remember like the core facets of what does cortisol actually do in the body, especially for LabMed, like thinking about these things quite scientifically in terms of the actual pathways that these hormones work in can be quite useful. Because as I said, sometimes the questions are a bit more testing kind of your knowledge of the basic principles rather than being overtly clinical. So, what do we know about cortisol? We know cortisol is our long-term stress hormone. And when cortisol acts in the body, it acts to increase the expression of sympathetic receptors, it acts to increase your blood sugar, it acts to increase deposition of fat. And that's why you get this characteristic Cushing syndrome appearance where people get increased weight gain, specifically around that abdomen. So we call that truncal obesity. So obesity that's specifically on your belly. You can also get these fat pads on your back, and the face usually gets quite round. So that's called like moon faces. And as your abdomen kind of gets quite big and it stretches, the skin starts to stretch, and you can get these things called striae, which are these purple bands on your belly. Now, what cortisol also does is it tries to increase your blood sugar, and it does this by breaking down various things in the body. And one of the things it breaks down is muscle. So people typically tend to get proximal myopathy, where they get muscle weakness in their proximal limbs. Um, and that's because cortisol is causing muscle breakdown. And finally, cortisol, as we know, also inhibits the immune system. And so you get poor wound healing and easy bruising because your immune cells aren't working very well. Now, you can also get mood disorders. There's this thing like steroid mania, where you give someone too much steroids, they go a bit manic. But that's quite low yield. That isn't tested too much. Um, Now, the complications are hypertension because we know cortisol increases the expression of sympathetic receptors, so that increases your blood pressure. You can get type 2 diabetes mellitus because cortisol is increasing your blood sugar, and it also leads to increased activity of osteoclasts in the bone, leading to osteoporosis. Now, in terms of the biochemical changes, this is something that's tested quite a bit. So we know it causes hyperglycemia. We've already talked about that. It causes hyperlipidemia and hypertension. We've already mentioned that. Now, the trends in your sodium and your potassium is tested quite a lot. And the point of this is you need to remember that cortisol can also act on aldosterone receptors. So when your cortisol gets high enough, the cortisol starts acting on aldosterone receptors. And when it does that, it starts acting a bit like aldosterone. So how does aldosterone affect sodium and potassium? It leads to reabsorption of sodium at the expense of potassium and acid. So typically what you get is you can get high sodium and low potassium. But in a question, they might not actually say that the person has low potassium, but the question might be, well, how could their potassium be affected? And the trend will be that the potassium will go down because sodium is being reabsorbed and potassium is being lost in exchange. So, in terms of investigations you'd want to do for Cushing's syndrome, I think this is quite a good way of thinking about it. So, our initial test, if we suspect someone has Cushing's, we can either do one of these three tests. We can do a 24-hour urine-free cortisol. We can do a late night salivary cortisol, and the reason we do it late at night is because cortisol release is pulsatile, and it's highest in the morning and lowest late at night. So it follows this diurnal rhythm. So if late at night it's high, that gives us some confidence that maybe this person is making too much cortisol. Now, then we get this thing about the dexamethasone suppression tests. So I think people get quite confused about this because you have the high dose version and the low dose version. So the point is that dexamethasone is basically a corticosteroid. So if you give someone dexamethasone, their cortisol should go down. Now, if you give someone a low dose of dexamethasone and their cortisol doesn't go down, that suggests that they might have Cushing's syndrome. Now, at this point, we can do a further test, which tells us, okay, what is the cause of this Cushing's syndrome? Well, the first thing we do is we measure serum ACTH. And so this tells us whether it's a problem with the pituitary making too much ACTH, so like Cushing's disease, where you have the pituitary making too much ACTH, and that is causing your high cortisol, or is it a problem in the adrenal gland? So if you have adrenal hyperplasia and your adrenal gland is pumping out too much cortisol by itself, your ACTH is going to be low. It's going to be suppressed. That's the same if you're taking too many steroids. That's also going to bring your ACTH down. So ACTH is going to be really useful for telling us, is this a problem with the pituitary gland or is it a problem in the actual adrenal gland? Now, next, what we can do is this high dose dexamethasone suppression test. Now, the difference between the low dose and the high dose is that the low dose isn't enough to suppress the cortisol being released in Cushing's disease. So if you have too much ACTH being produced and that is stimulating cortisol from the adrenal cortex, a low dose of dexamethasone isn't going to suppress that. But if you give a high enough dose of dexamethasone, you'll start suppressing that because it's still part of the HPA axis and there is some negative feedback. So if you give someone a high enough dose of dexamethasone, that's going to inhibit ACTH at the pituitary and it's going to inhibit cortisol release. But if instead of having this ACTH tumor that's causing the cortisol release, you have ectopic ACTH secretion, for example, in small cell lung cancer, even a high dose of dexamethasone won't suppress that because you don't have inherent negative feedback. If you have random ACTH secretion from some cells in the lungs, they aren't tuned to negative feedback. So even a high dose of dexamethasone isn't going to suppress them. So that's the difference between the low dose and the high dose. Low dose tells us that, okay, there might be Cushing's disease, Cushing's syndrome in the first place. And high dose tells us, okay, is this because of a tumor in the pituitary, or could this be because of ACTH secretion somewhere random, like in the lungs? Now, Addison's disease is kind of the opposite of Cushing's. It's adrenal insufficiency, and usually it's because of the destruction of the adrenal cortex. Now, one thing they sometimes like to ask is the cause, and in high-income countries, it's usually autoimmune. So you get autoimmune attack on the adrenal cortex, and usually you get antibodies against 21 hydroxylase. And in low-income countries, this is usually secondary to tuberculosis that can cause damage to your adrenal cortex. Now, the presentation is something you'd expect for having low cortisol. So you get weakness and fatigue, you get dizziness and orthostatic hypotension. Again, remember, cortisol leads to expression of sympathetic receptors, allowing adrenaline and noradrenaline to bind, and therefore raising your blood pressure. So if you don't have that cortisol, your blood pressure is going to be low. And you also get hyperpigmentation. So the reason for that is if you have low cortisol, if you have your adrenal cortex has been destroyed and your cortisol is low, your ACTH is going to try to go up to try to stimulate that adrenal cortex to make more cortisol. So your ACTH is going to keep on going up. And ACTH is made from a precursor called POMC. And POMC is cleaved to make ACTH and MSH. MSH is melanocyte stimulating hormone, and that stimulates your melanocytes to make pigment. So when you have high ACTH levels in Addison's disease, that leads to hyperpigmentation because you have all this high MSH as well, stimulating your melanocytes. And you also get salt cravings because obviously you're not reabsorbing enough salt. Because remember, we said this is total destruction of the adrenal cortex. So you lose cortisol and you're also losing aldosterone. So you're not having the effect of aldosterone on the kidney that allows retention of sodium, loss of potassium. So you get hyponatremia and hyperkalemia. You get hypoglycemia because you lose your cortisol, which causes increase in blood sugar. And you also get metabolic acidosis because you get decreased loss of protons. Because remember, just like sodium is exchanged for potassium, it can also be exchanged for protons. So if you have less of that exchange, you are retaining more protons and you get a metabolic acidosis. Okay, so again, looking at investigations, we want to look at serum ACTH, and that will usually be high because, as I said, it's trying to stimulate the adrenal cortex to make cortisol. You can measure morning cortisol. So again, remember, we said that cortisol is released in a diurnal rhythm. It's very high in the morning and very low at night. So if we want to check if it's too low, we want to check in the morning because it should be high in the morning. And that's why when we want to check if it's too high, we check at night because it should be low. You can also do something called a short synaptin test. Now, synaptin is basically a synthetic form of ACTH. And so you give this synthetic ACTH, and it should lead to a rise in your cortisol. But if it leads to a less than 2 times rise in the baseline, it basically means that your adrenal cortex isn't responding as it should, and you probably have Addison's. Okay. Cons is slightly different. It's a bit less high yield for the exams. It doesn't come up as much, but it's basically primary hyperaldosteronism. So too much aldosterone. So kind of similar to Cushing's, but instead of cortisol, it's aldosterone that's too high. And the causes are multifold. You can get adrenal hyperplasia. So again, your adrenal cortex getting too big and releasing too many hormones. You can get an adrenal adenoma that's spitting out aldosterone, or you can get an adrenal carcinoma that's splitting out aldosterone. And the presentation is usually going to be hypertension. And the way they'll phrase it is it will be treatment resistant hypertension. So it's someone that's got hypertension and we've tried to treat them with things like beta blockers or ACE inhibitors, and it hasn't really worked. And it's because they have too much aldosterone. So really what we have to do is we have to give them an aldosterone antagonist, something like spironolactone. And that's going to help them. So treatment resistant hypertension is a very common presentation of this. And again, the biochemical changes, think about your renin angiotensin aldosterone system. What does aldosterone do? It retains sodium at the expense of potassium and acid. So you get high sodium, low potassium, low acid. Okay. In terms of diagnosis, something that we measure is the aldosterone to renin ratio. So if we have too much aldosterone, that negative feedbacks on renin. So basically, we're going to have a really high aldosterone to renin ratio because our aldosterone is going to be high, our renin is going to be low because we have so much aldosterone. And then again, try to look for a cause. We can do a high resolution CT, specifically looking at the adrenals to see is there hyperplasia, is there an adenoma, is there a carcinoma? And you can also do adrenal vein sampling to see if that's where the aldosterone is coming from. Cool. So next, we're going to look at a different pathway in the HPA axis, which is going to be the growth hormone pathway. So again, let's take a quick break to do a question. So if you guys want to give the next question a go, I'm just going to change it now. So again, I'll give you guys a minute to give this next question a go, and we'll then have a quick talk about it and move on to talk about acromegaly. Okay, perfect. So it looks like everyone got that right. So well done. Yeah, so acromegaly, it basically is excess growth hormone, and it's most commonly because of a pituitary adenoma, as you guys clearly know. Um, but sometimes it can be a paraneoplastic syndrome, so growth hormone secretion from somewhere where there's a cancer, usually it's lung cancer. Um, And how it presents is quite important because that's how the questions are going to be phrased. So you're going to get someone that has frontal bossing, which means basically quite a prominent front of the head and a prominent forehead, which is basically a part of that. They'll have coarse and sweaty skin. They'll have a very large nose. They have a big tongue, which is macroglossia. The hands and feet will be characteristically large. So the question might say something about, oh, they've needed to get a increase their shoe size. Their shoes have stopped fitting, or they needed to get a bigger hat. That's usually how they phrase the question. Prognathism is a big jaw. And so the complications of this are threefold, the main one. So you can get carpal tunnel syndrome, and this is mainly because of the fact that growth hormone leads to the production of glycosaminoglycans. So if you look at the diagram on the right, you can see growth hormone. Oh, was that a question? No. Okay. So if you look at the diagram on the right, it shows that there's an increase in chondroitin sulfate because of growth hormone, and that is a glycosaminoglycan that can deposit in the carpal tunnel and lead to carpal tunnel syndrome. Um, in terms of the heart, usually it can lead to problems with the heart, and this is usually in kids. So, as you guys know, in kids you don't get acromegaly, you get gigantism because your epiphyseal plates haven't fused yet, so you get really big. And in those people, their heart usually gets affected, so most of them die because of a dilated cardiomyopathy. And you also get hypertension and type 2 diabetes. The reason you get type 2 diabetes is because growth hormone stimulates an increase in your blood glucose. So it's kind of inhibitory to insulin. It does the opposite of insulin. Um, yeah, so in terms of your diagnosis, you want to look at serum IGF-1. So that's what growth hormone releases from the liver. So you get growth hormone releasing hormone from the hypothalamus, leading to the release of growth hormone from the pituitary, and that stimulates the release of IGF-1 from the liver. Now, one other thing we can do is what's called an oral glucose tolerance test. And that's actually a better way to measure it because IGF-1 can sometimes be a bit hit or miss. So when we do an oral glucose tolerance test, we basically give them glucose and it should suppress growth hormone because remember, growth hormone leads to an increase in glucose. So there's negative feedback there from glucose onto growth hormone. And if it doesn't suppress it, then we know that there is a problem with increased growth hormone secretion. And we can do an MRI to look for the pituitary adenoma, which is the most common cause. Okay. Moving on to the prolactin axis. Hyperprolactinemia is something that comes up quite a bit, and it's a high serum prolactin, basically. There are a number of different causes, but the most common, again, is going to be a pituitary adenoma releasing prolactin. And actually, the pituitary adenoma, the most common thing it releases will be prolactin. So prolactin is the most common, and then growth hormone is the second most common. It can be caused by medication, so most characteristically antipsychotics, which inhibit the dopamine axis. And as we know, dopamine is the only thing, this is the only axis that has inhibitory regulation where dopamine inhibits prolactin release. So if you have dopamine antagonists, you get high prolactin. Hypothyroidism can lead to high serum prolactin, and we'll talk about that very shortly because there's a good diagram coming up which will show us why. And it can be physiological in pregnancy. So if you look at this diagram on the right, it kind of explains why in hyperprolactinemia you get in women you get amenorrhea, so the lack of a period, or galactorrhea, so production of breast milk, and in men you get gynecomastia and erectile dysfunction. It's because basically what happens is that prolactin inhibits the release of GnRH, which is the axis that stimulates the release of LH and FSH from the pituitary. So when you have prolactin that's too high, you basically get an inhibition of FSH and LH. And so you're going to get a reduction in your sex hormones. So you're going to get sexual dysfunction, amenorrhea in women, erectile dysfunction in men, and the galactorrhea and the gynecomastia is because prolactin stimulates the breast tissue and stimulates it to produce milk. and we can just test our serum prolactin to see if it's elevated. It's quite a straightforward diagnostic test. Okay, so we talked briefly about two of the most common pituitary adenomas, so prolactinomas and growth hormone releasing adenomas. Um, there are basically two types of adenomas. There can be microadenomas if they're less than 10 millimeters, or macroadenomas if they're more than 10 millimeters. And the presentation will depend on what they're secreting, so growth hormone or prolactin, rarely thyroid hormone, and sometimes what can happen is that you can get pituitary stalk compression. So the adenoma compresses the pituitary stalk, and in this case, everything is going to be low, typically except your prolactin, because it means that there's less dopamine getting to the prolactin secreting cells, so your prolactin tends to go up. And you get this kind of bitemporal hemianopia where you lose your outer visual field. Okay, so again, another quick question if you guys want to go do that. I'll give you a minute and we can discuss that and then continue. So I'll just change the question on Socrative now. Okay. Um, yeah, so essentially the question is asking us about someone with hypopituitarism and it's asking us, okay, what do we have to commence first? And so the answer to this is hydrocortisone, and the reason is because basically if you get panhypopituitarism, you lose most of your things except prolactin. And the biggest issue that happens is this thing called Addisonian crisis. So basically a very acute form of Addison's disease where you're making no cortisol. And the problem with making no cortisol is that, as I said, cortisol increases the um, expression of sympathetic receptors. So things like alpha 1 that adrenaline and noradrenaline can act on to increase your blood pressure. So what can happen in this Addisonian crisis is you can get low blood pressure and giving adrenaline or noradrenaline won't help because there is no cortisol. So all those receptors are downregulated. So in order for adrenaline or noradrenaline to be able to increase your blood pressure in these situations, you need to give hydrocortisone, so a corticosteroid that basically then increases the expression of these sympathetic receptors so that adrenaline and noradrenaline can act on them and increase your blood pressure again. So that is basically, yeah. So it's a combination of a pituitary problem and an adrenal problem where you get this thing called, yeah, acute Addisonian crisis. So very acute Addison's disease. Um, So hyperpituitarism in general is insufficiency of more than one pituitary hormones or having too much prolactin, which can count as one of the things. And the causes can be trauma. So typically in car accidents, where there's acceleration and deceleration of the head. Sheehan syndrome, which is where after pregnancy there's a big postpartum hemorrhage, which leads to ischemia of the pituitary. You can get a really big macroadenoma causing basically damage to the pituitary, something we call pituitary apoplexy, or it can be infiltration with other things, so things like iron and hemochromatosis or sarcoidosis. Okay, so that is all the basic endocrine biochemistry. We're now going to move on to adrenal tumors. So there's only really one that you guys need to know about, and that's pheochromocytoma, which is a neoplasm of the adrenal medulla. So it leads to the release of catecholamines, so adrenaline and noradrenaline. And there's this thing about the rule of tens. So there's loads of tens related to it. The main thing is that 10% of them are malignant, and 10% can be bilateral. Now, it can be sporadic, but there are also some familial syndromes where you can get pheochromocytoma, and we'll talk about those later in the talk. So again, there's another question for you guys to do. I'll just change that now. So if you can do that quickly, and then we will continue. Okay, cool. So before we move on to discussing the question, let's just talk about the clinical presentation of pheochromocytoma. Now, the key point about it is that everything that happens, all the symptoms you get are episodic, because the way pheochromocytoma works is that the tumor randomly releases catecholamines sporadically. So you get symptoms whenever it does this transient release of the catecholamines. And the symptoms are like you'd expect. If you get a sudden surge of adrenaline and noradrenaline in your system. You get tachycardia, palpitations, you get really sweaty, and they can develop this intermittent hypertension and headaches because of the high blood pressure. So if you measure someone's blood pressure, it might not necessarily be high, but that doesn't mean they don't have pheochromocytoma because the blood pressure typically shoots up during these sporadic episodes. So that's the key thing to remember for pheochromocytoma is that it's all sporadic. It happens intermittently, and that's when they get their symptoms. So in terms of diagnosis, well done to those of you that got the 24-hour urinary metanephrines. So metanephrines are basically the breakdown products of catecholamines. Um, Urinary catecholamines aren't a very good diagnostic test. Metanephrines are better. They have higher diagnostic accuracy because obviously if you have more catecholamines in your circulation, you're going to get more metanephrines, and they are excreted through the urine. So over 24 hours, if your urinary metanephrines are through the roof, that suggests you have a very high level of catecholamines in your system. And the reason we collect over 24 hours is because if we just collect it at one time point, we don't know how many surges, how many sporadic releases have occurred during that time. And then we can also do a CT or an MRI to look for the tumor. And we can do a gene panel because, again, it is related to some inherited conditions. Okay, moving on to the thyroid. Um, Starting off with hyperthyroidism. We know that that is excess thyroid hormone, and it can be either primary, so due to a problem in the thyroid itself, or it can be secondary, so a problem in the signaling pathway, so either from the pituitary or the hypothalamus. So in terms of primary hyperthyroidism, it's most commonly caused by Graves' disease, but can also be due to thyroiditis, a thyroid nodule that's toxic. So when we say it's toxic, it basically means that it's releasing thyroid hormone. Most nodules are not toxic. So when you hear toxic, it means it's releasing thyroid hormone. Or it can be a toxic multinodular goiter, um, where basically you have a big thyroid gland with multiple nodules that are all releasing thyroid hormone. A secondary cause can be a pituitary adenoma. Again, not as common, doesn't usually release TSH, but can do. And that can also lead to high thyroid hormone. The presentation is obviously related to what thyroxine does in the body. So it's obviously associated with increasing your metabolic rate. It can increase your blood sugar. It increases your gastrointestinal function, and it also it has a very wide range of effects. So I'd say the best way to remember this is related to this idea of sympathetic symptoms. So people with hypothyroidism typically get palpitations, they're very sweaty, they have warm intolerance, they're always really warm, and they lose weight. So they just start losing weight. So I'd say the sympathetic symptoms are kind of the most prominent, um, and that's kind of how you're gonna recognize it during exams. But you also get this kind of sexual dysfunction, and that's because thyroid hormone interferes with prolactin as well. So TRH, the thyroid releasing hormone, actually stimulates prolactin. So if you have hyperthyroidism, where you have low TRH levels, that can lead to low prolactin, and again, that can cause issues with your sexual function. Um, and again, diarrhea is associated with the fact that thyroid hormone acts with the gastrointestinal tract. So again, another question for you guys on the thyroid. Please give that a go, and then we will continue. Okay, cool. So I think this is actually quite a tricky question, and this kind of makes you think about the idea of primary versus secondary hyperthyroidism. So if I just go back quickly to the previous slide, remember primary hyperthyroidism means that it's a problem in the thyroid. The thyroid is making too much thyroid hormone by itself. And because of that, it's going to lead to low TSH because of the negative feedback. Now, in secondary hypothyroidism, that problem is because the pituitary gland is making too much TSH, which is activating the thyroid to make thyroid hormone. So in that case, you're going to have high TSH. So TSH is a really, really useful factor for you to be able to differentiate between primary and secondary hyperthyroidism. And that's something that's like a slightly trickier question that they might try to catch you out on. So make sure that when someone is presenting with hypothyroidism, you look at their TSH. Is it high or is it low? Because that's going to tell you whether the problem is originating in the thyroid itself or whether it's secondary because of a problem in the pituitary that's activating the thyroid. Okay, now we said Graves' disease is by far the most common cause of hyperthyroidism, and the mechanism is antibodies against the TSH receptor, which leads to continuous stimulation of the TSH receptor and the thyroid to release thyroid hormone. Now, it's quite high yield to know that Graves' disease does obviously present with the classic features of hyperthyroidism, but it has two features that are specific to Graves itself. One is exophthalmos, so these kind of bulging eyes, your eyes kind of bulging out of their sockets, and pretibial myxedema, which basically means swelling of your legs, but not because of fluid accumulation. Um, and the reason both of these occur is because thyroid hormone stimulates the production of glycosaminoglycans. So it stimulates fibroblasts to release these molecules, and they build up most prominently around the eyes, causing the swelling of your eyes, and in your legs, in your shins. So that's why when you do a thyroid exam, you look at the eyes and you look at the legs. And that's to look for features of Graves' disease. So they're quite specific to Graves' disease, but obviously it also presents with the classic features of hyperthyroidism. Okay. Hypothyroidism, in contrast, obviously is the opposite. You have a deficiency of T3 and T4. Again, this can be primary. It's if it's primary, it means there's a problem in the thyroid. So this could be iodine deficiency. Thyroiditis. Again, at this point, it might be a bit confusing. Thyroiditis can cause both hyper and hypothyroidism, and we'll talk about why that is. It can be iatrogenic, so drug induced. Most commonly, things like amiodarone can cause hypothyroidism, or it can be congenital. So congenitally, your thyroid gland just doesn't develop. If it's secondary, it means that the thyroid is working fine, but it's not getting the signals from the pituitary gland. So again, TSH is going to tell you the answer here. If your TSH is high, it means the pituitary gland is working fine. It can sense that there's low thyroid hormone and is trying to stimulate it. If it's secondary, it means that TSH is low because the problem is originating in the pituitary gland. It's not making enough TSH to stimulate the thyroid, and the negative feedback doesn't work on the pituitary gland. Um, so again, looking at your TSH levels is really important. The presentation of hypothyroidism. Again, you can remember all of the things individually, but I think it's quite useful to remember that it's kind of just the opposite of hyperthyroidism. And again, focusing on the kind of sympathetic systems in hypothyroidism and taking the opposite. So in hyperthyroidism, you're intolerant to warmth. In hypo, you're cold intolerant. You gain a lot of weight. You might have a slow heart rate. So again, it's kind of the opposite of the sympathetic symptoms, sorry. And it's also the skin and hair findings are also quite useful to know. So they usually have quite dry skin and brittle nails. So brittle nails, dry skin, and again, the hair is also quite like dry and it breaks quite easily. So it's brittle usually. Um, so those are the kind of characteristic symptoms of hypothyroidism. Talking about thyroiditis, which is inflammation of the thyroid gland, there are a few different types, which LabMed does test sometimes. And so the overall idea why thyroiditis can cause hyper and hypothyroidism is because when there's inflammation of the thyroid, what happens is that it releases all of its thyroid hormone at once. So you kind of get this initial state where the thyroid has just gone inflamed and it's releasing all this thyroid hormone that it has. And that causes an initial hyperthyroidism. But then once it's done that, as the inflammation continues, the thyroid stops working very well and it can't make more thyroid hormone. So you then start getting a hypothyroidism. So typically in thyroiditis, you have an initial hyperthyroidism followed by a hypothyroidism. Now, the most common type of thyroiditis and also the most common cause of hypothyroidism is Hashimoto's. So Hashimoto's is an autoimmune attack on the thyroid. It's a type 4 hypersensitivity, so it's mediated by T cells, primarily CD4 T cells coming into the thyroid and causing inflammation and damage. Um, although some people get confused because you also see antibodies in Hashimoto's, and actually the screening test is looking for antibodies against TPO, so thyroid peroxidase. And so some people sometimes get confused and think it's a type 2 hypersensitivity where the antibody is causing the damage, but it's not. So it's a type 4 hypersensitivity. The antibody is formed as an epiphenomenon. So the antibody is there, but it's not causing the damage. So it's a type 4 hypersensitivity, but the antibodies are formed and they're useful for diagnostics. So we look for TPO antibodies to diagnose Hashimoto's. Renal thyroiditis is related to antibody as well, but it's the deposition of antibody in the thyroid that leads to chronic inflammation and fibrosis. And typically, the presentation of renal thyroiditis is going to be a very, very hard thyroid. So all this chronic inflammation and fibrosis is going to lead to hardening of the thyroid. And it's going to be on palpation, usually the thyroid is very soft. Even if you have a goiter, it's still quite soft. Renal's is going to be a very hard thyroid. The Quervains is usually secondary to viral infection. So you get a viral infection, it starts affecting your thyroid, and it's kind of an immune response to the viral infection hitting your thyroid by accident. And it leads to granulomatous inflammation of the thyroid. And initially, we get this hyperthyroidism followed by the hypothyroidism. But it's usually self-limiting. So you go initially hypo, and then come back to normal. Whereas in Hashimoto's, you go initially hyper, come back down to hypo, and usually stay hypo. Yeah, so De Quervain's is secondary to viral infection. It's temporary, and the big thing about De Quervain's is it presents with a painful thyroid. So I remember it as De Quer pain. It helps me remember that it's the only one that's associated with a painful thyroid. So Riedl's is a hard thyroid. De Quervain's is a painful thyroid gland. Um, and you can also get other causes of thyroiditis. So drugs can sometimes cause it, but those are less kind of high yield. These three are the kind of most important ones to know about. In terms of our investigations, we want to do thyroid function tests for all of them. Obviously, we want to look at our T3 and T4. And in all these cases, we know it's going to be a primary problem. It's a problem in the thyroid. So depending on when we find it, the T3, T4 is either going to be high or low. In Hashimoto's, anti-TPO antibodies are quite good for helping us diagnose, but then it's not fully specific. So we'd want to still do a biopsy to look for this infiltration of CD4 T cells into the thyroid. Again, for the other two biopsies important as well, we see dense fibrosis in renals, and we see this granulomatous inflammation in De Quervain's. Um, Cool. So something that comes up a little bit is this idea of multinodular goiters. And I think it can be a little bit confusing sometimes because you can get a goiter in loads of conditions. So Graves causes a goiter, so does Hashimoto's. And I think it's a bit hard to wrap your head around how hyper and hypo can both cause goiters. But essentially, um, those kind of diseases we talked about, so things like Graves and Hashimoto's, they cause diffuse goiter. So you get this kind of symmetrical enlargement of the thyroid gland that's quite smooth. Now, in multinodular goiter, you get this very lumpy thyroid that's caused by these nodules. And it's actually the most common cause of enlargement of the thyroid. And so, unlike Graves and Hashimoto's, where you get this symmetrical enlargement of the thyroid, a multinodular goiter is going to be asymmetric. And it can be idiopathic, it can be because of iodine deficiency, and most importantly, a normal multinodular goiter is going to be euthymic. It's not going to be hyper or hypothyroid. So that's the important thing to remember. So sometimes they can ask that, what would the findings be on thyroid function tests? Usually, a multinodular goiter is going to have normal thyroid function tests. Um, yeah, it's a gradual onset. It's an irregular midline mass. If it gets big enough, it can cause problems with swallowing and speech. And that's because of compression of your trachea and your esophagus, because obviously your thyroid sits just in front of those structures. And in some cases, it can become toxic. So remember, I said toxic just means that the nodules are releasing thyroid hormone. So when it becomes a toxic multinodular goiter, that's when each of these nodules are releasing thyroid hormone and you become hyperthyroid. You get this thyroid toxicosis, this very acute high increase in thyroid hormone. The investigations we do is thyroid function tests. Usually, as I said, it's euthyroid unless you've got a toxic multinodular goiter. And we tend to do an ultrasound to look at the nodules to make sure they don't look too alarming. And usually they will be hyperechoic, so they'll look quite dark on the ultrasound. Um, and you'll see them across both lobes, and that's important because that differentiates it from something like cancer, which might be just unilateral. So again, have a go at this next question, and then we will move on. It's quite a short one, so hopefully we can do this one quickly and keep going. Cool. Everyone remembers that the quaveins is associated with pain. Good. Okay. We're now going to move on to cancers of the thyroid. Um, and we'll start off by talking about a follicular adenoma, which isn't actually a cancer, it's benign. And it just presents as a painless solitary midline nodule. So remember, a nodule by itself is usually more alarming than multiple nodules because multiple nodules is usually a multinodular goiter. But if you see someone with a single nodule, that can be more indicative of cancer. Um, and the investigations for cancer are usually euthyroid. So again, the thyroid cancers don't usually secrete thyroid hormone. And the way we investigate, we do what's called a fine needle aspiration. So we put a needle into the nodule and we take out some of the cells and we look at them on a slide. And in this case, you're going to see a homogeneous spread of these follicular cells. And in terms of treatment, what we can do is a hemithyroidectomy. And you might think, oh, well, if it's benign, why would you do that? And we'll talk about why we do it in one second when we talk about the differential diagnosis, which is follicular carcinoma. So follicular carcinoma is very similar to follicular adenoma, except it is malignant. So it actually invades beyond the thyroid capsule. And that is kind of the main difference between the two. Histologically, they actually look very, very similar, but one of them spreads beyond the thyroid capsule. So again, it presents very similar to follicular adenoma. It's this painless, solitary midline nodule that grows quite slowly. If we do thyroid function tests, again, it's going to be euthyroid. These don't secrete thyroid hormone. If we do a fine needle aspiration even, they look very, very similar. Um, and what you can do sometimes is what's called a radioisotope scan, which is where you give a radioisotope of iodine and you check what areas of the thyroid take up most iodine. And so if you have something like a toxic multinodular goiter, all these toxic nodules would take up iodine because they're obviously making and releasing loads of thyroid hormone. But usually cancers, as I said, are euthyroid. They don't usually release thyroid hormone. So it would look cold. There won't be any uptake of iodine. And so the reason we do a hemithyroidectomy is because of this next point. It is not possible to differentiate between follicular adenoma and follicular carcinoma based on a fine needle aspiration. So if we do a fine needle aspiration of a thyroid nodule, and we find that okay, it looks quite follicular, it could either be follicular adenoma or follicular carcinoma. There's no way for us to tell apart from taking out the thyroid and looking whether it has gone past the thyroid capsule. And so that's why we tend to do hemithyroidectomies for people with these conditions because you can't know whether it's a follicular carcinoma or a follicular adenoma just by taking a FNA biopsy. Well, something they do also ask sometimes is what is the mechanism of spread of follicular carcinoma? And it's usually hematogenous, so it goes via the blood, which is in contrast to the next tumor, so papillary carcinoma, which spreads lymphatically. So papillary carcinoma is the most common type of thyroid cancer. And as I said, it spreads to lymph nodes. It doesn't spread in the blood like follicular carcinoma. And it's most commonly seen in young women. And a key risk factor for this is childhood irradiation. So if people had childhood cancers and they were given radiotherapy for these, it can increase their risk of developing papillary carcinoma of the thyroid. Um, Again, the presentation of most of these thyroid cancers is quite similar. They're these solitary, slow-growing nodules. In papillary carcinoma, you can get lymphadenopathy if it's spread to the lymph nodes. But otherwise, you're usually quite well. Again, they don't release thyroid hormone, your euthyroid. You can do an ultrasound to look at the nodule. FNA, in this case, is diagnostic. So based on the FNA, you can diagnose papillary carcinoma. And there's two key histological things that are asked about sometimes. One is orphan Annie eyes, which I've shown you guys a picture of on the right. So there are these kind of cells that have a clear cytoplasm. So they look like eyes. And you can also get these things called Samoma bodies, which are basically calcium deposits that form rings. And you get them in papillary carcinoma. You can get them also in meningiomas. So there are a few things that can cause Samoma bodies, but it's just important to know that these are two histological findings specific to papillary carcinoma. And again, we treat it with a hemithyroidectomy. Medullary carcinomas are a bit more niche. They are the malignancy of the parafollicular C cells, which release calcitonin. And these, unlike the other types of thyroid cancer, can actually hypersecrete. So while other types of thyroid cancer don't secrete thyroid hormone, these cancers, because they're cancer of parafollicular C cells, they actually do secrete calcitonin. And it can be sporadic, but again, it can also be part of a familial inherited cancer disorder called MEN, which we will discuss very shortly as well. Um, Again, presentation very similar between all of them. You get this single nodule. In this case, you can get more symptoms if you have excessive calcitonin release. So calcitonin can lead to flushing and diarrhea. And finally, you can do an FNA to um, basically diagnose this. Cool. So finally, we have anaplastic carcinoma. Now, anaplastic carcinoma is the most severe by far. You get these undifferentiated cells that grow super rapidly. They invade the surrounding structures. You usually see it invading the trachea and the esophagus. So that's usually the mechanism of death in these cases. Yeah, so it's got a very, very poor prognosis. It invades into the airway, and that's usually what kills these patients. It's quite rare, and it mostly occurs in the elderly, so it's like an age-related thing. But yeah, all you have to know is very undifferentiated cells, very poor prognosis. Yeah, in this case, it's a rapidly growing mass. So all the other cancers we've talked about are quite slow growing. This one is rapidly growing. It causes compressive symptoms. You get dysphagia, hoarse voice, difficulty breathing. And again, FNA will show undifferentiated cells, and you can do a CT to check how much it's invaded. Okay. Finally, to finish off, we've got our MEN syndrome, so multiple endocrine neoplasia, and I used to find these really, really hard to remember until I found this, which I think is quite a good mnemonic. So you've got MEN1, MEN2A, and MEN2B. So MEN1 is caused by a mutation in the MEN1 gene, quite straightforward, whereas MEN2, both the MEN2s are caused by mutations in the RET oncogene. That's why they're both MEN2s. Now, the cancers they cause are a bit different. So the way you remember them is MEN1 causes the three Ps. So that's a pituitary adenoma, a pancreatic endocrine tumor, so usually something like a gastronoma or an insulinoma. So pancreatic tumor that secretes something endocrine. And you get a parathyroid adenoma. MEN2 has two Ps and one M. So it shares one of the Ps with MEN1, which is the parathyroid adenoma. It also causes pheochromocytoma and medullary thyroid carcinoma. So remember the type that is related to the parafollicular C cells. And MEN2B has one P and two Ms. So the one P is pheochromocytoma, which it shares with MEN2A. It also shares medullary thyroid carcinoma, and then it also causes these mucosal neuromas, which are basically these bumps on your tongue. So basically, if you see pancreatic endocrine tumor, you should be thinking MEN1. If you see this medullary thyroid carcinoma, which is the most common way they test it, you should be thinking MEN2A or MEN2B, so just MEN2 in general. Um, and then sometimes they might throw in that, okay, the person has a mucosal neuroma, in which case it's MEN2, or the person has a parathyroid adenoma, in which case it's MEN2A. But I think that's usually quite harsh. Usually the questions are phrased in a way that you just find that it's men two or men one rather than differentiating between men 2A and men 2B. But I'd say this is actually quite high yield to learn. It's worth learning. Okay. So moving on to our glucose homeostasis. Oh, actually, there was one question here. So last question for the thyroid. Do you just want to do that quickly and then we'll get cracking? Cool. Perfect. All right, glucose homeostasis. Let's get into it. So, type 1 diabetes, pretty straightforward. Autoimmune destruction of your pancreatic beta cells. The risk factors you're going to be looking at for other autoimmune diseases. You're going to be looking out for things like Hashimoto's thyroiditis in the family, asthma in the family, things like that. Presentation, you're going to get thirst, polyuria, and nocturia. You also get weight loss, and the reason for that is kind of shown in our schematic. Insulin leads to the buildup of substances, it builds things up. So if you have low insulin, you're going to get more breakdown of things, including proteins and fats. So you lose weight. And then obviously all the glucose in your blood is going to lead to a diuresis. So you pee a lot and you therefore get thirsty. You can get a diabetic ketoacidosis, which is polydipsia, polyuria dehydration, and it's obviously because of the production of ketones. Ketones are acidic, they increase the acidity of your blood, and the reason you make ketones is because ketones are usually produced in the starved state when insulin is low. So if you have low insulin, your body thinks it's starving, it starts making ketones. Everything gets a bit too acidic and you get diabetic ketoacidosis. This is very, very common in type 1 diabetes. It's usually the first presentation of type 1 diabetes, and very, very uncommon in type 2 diabetes. So diabetic ketoacidosis should be pointing you towards type 1 diabetes. Um, and very quickly, we do have a question at this point. So I'll just change the question. You guys want to try this one out? And then we'll keep it moving. Okay, good. I think it's a bit of a tricky question because it's worded weirdly. Remember, the person is hyperglycemic and asked which one is the least likely to account for that. Insulin reduces blood glucose. All the other things listed increase blood glucose. So it's important to know glucagon, cortisol, adrenaline, and growth hormone all increase your blood glucose level. Um, okay, so type 2 diabetes is a progressive decline in beta cell function, and you get less sensitivity to insulin. This is more because of lifestyle factors like obesity, physical inactivity. Again, you can get similar symptoms, polydipsia, polyuria, and typically because it's associated with these poor lifestyle factors, you can get these specific complications. So you get these microvascular complications and macrovascular complications. So microvascular relates to obviously small vasculature. That's the vasculature in your eyes causing retinopathy, vasculature in your kidneys causing nephropathy, and vasculature supplying your neurons causing neuropathy. Or you can get macrovascular complications, which is this your stroke, your myocardial infarction, your peripheral artery disease. The mechanism behind these is twofold. Usually, you get the main mechanism is you get glycation of proteins, and these glycated proteins can deposit themselves in tissues and cause all sorts of problems. And you can also get sorbitol accumulation in tissues, which brings water with it. So that's the most common cause of the nephropathy. So sorbitol accumulates in Schwann cells, water follows sorbitol, Schwann cells blow up and die. Um, in type 2 diabetes, you get this hyperosmolar hyperglycemic state where low insulin leads to very, very high glucose levels, um, which leads to a lot of urination. You get very dehydrated, but you don't get ketones. So it doesn't actually become an acidosis. In terms of diagnostics, there are four ways you can diagnose it. You can do a random plasma glucose level above 11.1 moles in the presence of symptoms of hyperglycemia, or you can have a fasting plasma glucose over 7, a plasma glucose level over 11 2 hours after an oral glucose load, or you can have an HbA1c over 48. But remember, HbA1c can be unreliable if there's anything affecting the length of survival of your blood cells. You do get, again, antibodies in type 2 diabetes, type 1 diabetes. But remember, type 1 diabetes, again, is a type 4 hypersensitivity. So the antibodies are present, but they're not the cause of the pathology. And your C-peptide is usually undetectable in type 1 diabetes. Yeah, so this is just something to think about, the conditions that falsely elevate or falsely reduce HbA1c. Not super important or high yield, but something to refer to if you really want to get all the marks. There are also some more niche conditions, so like maturity onset diabetes of the young, autosomal dominant disorders that lead to impaired insulin secretion. Um, Usually they present a bit later than type 1 diabetes, so you can get it in your 20s, and it can be asymptomatic. Gestational diabetes, again, not super high yield, but worth knowing that it's new onset diabetes during pregnancy. So it has to be, I think, after 24 weeks. It's associated with high BMI, having a large baby previously, having gestational diabetes before. And the reason it's a problem is because it can lead to a very big baby that will need a C-section. And it can also increase your risk of preeclampsia. So one thing that can come up a little bit related to glucose homeostasis is hypoglycemia, just because it is a bit of an emergency. And there's loads of different things that can cause hypoglycemia. So type 1 diabetes, if you take too much insulin, Addison's disease because of low cortisol. Again, if you take too much insulin or sulfonylureas, if you're ill and you're diabetic, and insulinomas, so pancreatic tumor releasing too much insulin, they can all cause hypoglycemia. And hypoglycemia has kind of quite severe neurological symptoms. So you get confused, you get altered speech, your GCS can go quite low. So it's really quite dangerous, and it can lead to irreversible brain damage if it's not treated fast enough. So it's really important to be able to spot someone comes in, they're confused, altered speech, they've got reduced cognition, check their glucose, especially if they're diabetic and they're taking things like insulin or sulfonylureas. Again, another quick question for you guys to do before we move on. And then we're going to get into the more renal stuff after this. Okay, in the interest of time, I'm just going to move on. But yeah, well done to everyone who did get that. So, type 1 diabetes, you're going to have no C-peptide. That's quite a good measure of how your pancreas is doing. Okay, so moving on quickly for the last 20 minutes to the kidney and the urogenital system. It's going to be a quite broad overview, just the key points for you guys to think about, and the things that mainly come up. So it's not going to be like a huge deep dive, but all the important points will be hit, hopefully. Okay, so some things we're going to cover is AKI, so acute kidney injury, renal tubular acidosis, kidney stones, the much feared nephrotic versus nephritic syndromes, UTIs, and tumors. So starting off with AKI, the definition is actually quite important. They can sometimes ask questions about that. So it can be a rise in creatine of more than 26 micromoles per liter within 48 hours, or serum creatinine more than 1.5 times the baseline within the last 7 days, or a urine output of less than zero point 0.5 milliliters per kg per hour for more than 6 hours. So it can be any of those three. Usually it'll be the creatinine going up by more than 1.5 times the baseline in the last 7 days. Now, for AKI, there are three different types, and they do love asking questions about, okay, what type of AKI is it? All you need to know is subdivide it in your head as pre-renal, intrarenal, and post-renal. So things happening before the kidney, in the kidney, and after the kidney. A pre-renal is basically always going to be something causing reduced blood flow to the kidney. So whether that's a heart attack causing cardiogenic shock, your heart isn't pumping well, there's no blood going to your kidneys. It can be sepsis, huge vasodilation, no blood to the kidneys. It can be burns causing extravasation and low blood pressure. So anything that reduces blood flow to your kidneys can cause pre-renal AKI. Intrinsic renal is basically things that are affecting the kidney itself directly. So the most common thing is acute tubular necrosis, which is usually caused by either ischemia or nephrotoxins. So I used to be a bit confused about this because I used to think, okay, well, I thought ischemia causes pre-renal AKI. So the way you should think about it is if you get low blood flow to the kidney, initially you get this kind of pre-renal AKI, the kidney compensates a little bit, the RAS system gets activated, it tries to maintain blood flow to itself. If that reduced blood flow persists a little bit and you actually get ischemia in the kidney, that's when you start getting acute tubular necrosis, which is when the cells in the proximal tubule start dying and they slough off and you find them in the urine as these muddy brown casts. So that's when ischemia causes it, or it can be caused by toxins that are like, toxic to the kidney, so things like amphotericin B, used in fungal infections. Acute interstitial nephritis is typically caused by NSAIDs, and you kind of get inflammation in the kidney parenchyma, so not in the tubules, but around the tubules. Or it can be a glomerulonephritis, which we'll discuss. Post-renal means that there's an obstruction in the kidney. And because there's an obstruction, so somewhere in the urogenital tract, it can be in the ureter, it can be in the urethra even, so something like BPH. Because of this, all the urine backs up and it goes all the way back up to the kidney, and causes a reduction in urine output, and it causes an elevation in creatinine because you're not clearing all the creatinine from your system. In terms of the test results, the things you should know are that AKI will cause a rise in your potassium, because remember, kidneys are important for getting rid of excess potassium, and it'll cause a metabolic acidosis because, again, the kidneys are important for getting rid of excess acid. How would it present? It can have a number of presentations. So typically you can get some ECG changes that can be caused by a high potassium. So remember your tented T waves. You can get pericarditis, which can be caused by high levels of urea. So we call that uremic pericarditis. And you can get itching as well because of this urea depositing in your skin. Now, what can be useful is to think about the difference between AKI and CKD. Well, CKD is a kind of more chronic dysfunction in your kidney. And on the right, you can see some of the differences between AKI and CKD. And the way you should think about it is essentially that CKD will be a long-term progressive thing. And AKI can happen in a matter of hours or days. CKD will have progressed for a long time. So some of the things will have been compensated a little bit, whereas others will be slightly worse. So, for example, your potassium will be much higher in an AKI compared to a CKD because, in a CKD, some compensation has happened. The RAS is going to be trying to compensate a little bit for the high potassium and things like that. Um, so those things are important to keep in mind. Um, Renal tubular acidoses are a little bit confusing. Again, not super, super high yield, but can come up sometimes. Essentially, they're your non-anion gap metabolic acidoses. So your anion gap isn't elevated, it's normal. And there's three different types. And the way I'd remember it is kind of the primary disturbance. So type 1 is when you can't secrete H plus ions in your distal tubule. And because of that, you retain all of that H plus, and your urine is going to be quite alkaline. That's probably the worst one. It causes the most severe acidosis. Type 2 is when you can't reabsorb bicarb in your proximal tubule. And because you can't reabsorb the bicarb, more bicarb is lost in the urine, and that causes an acidosis. But unlike type 1, your urine isn't going to be hugely alkaline because you still get some of that H plus secretion, which is probably the most important aspect of maintaining acid-base balance. Type 4 is a bit more complicated, and it's because basically you should think of it as having a resistance to aldosterone. So what aldosterone usually does is it causes the reabsorption of sodium in exchange for hydrogen ions, which are lost in the urine. So if we get less of that action, less of that exchange between sodium and potassium, sodium and H plus, we're going to get less H plus being lost in the urine. There used to be a type 3, but they found that that was just a combination of type 1 and type 2 together. So that's why we now have type 1, type 2, and type 4. So just remember, normal anion gap metabolic acidosis, no H plus secretion in distal tubule type 1, no bicarb absorption in PCT type 2, and no aldosterone action type 3. Sorry, type 4. Um, Renal stones are the formation of calculi in the renal system. The most common type is calcium oxalate. You can also get you can get calcium phosphate as well, which is less common. So calcium oxalate is the most common type. You can get these things called triple stones or struvite stones, which are made up of magnesium, ammonium, and phosphate. And these typically cause these huge staghorn calculi that are really big and can cause a lot of problems. So all the other stones usually can pass just in the urine by yourself. They're really painful, but you can pass them. Staghorn calculi, you can't pass usually. And the symptoms typically are going to be urinary colic. So it's classic loin to groin pain. You can get hematuria because of the stones causing damage to your bladder epithelium. And you can get obstruction. So if the stone is big enough, it can obstruct and you can get hydronephrosis. But that is if the stone is really stopping all urine flow. If it's stopping urine flow, then the urine stasis means that bacteria can stay in the renal system and go back up to the kidney and cause pyelonephritis. So again, just a quick question to test your understanding. If you guys can jump onto the Socrative quickly and try the next question, that would be great. Oh, actually, sorry, it'll be this one. Okay. Perfect. Yeah. So these struvite stones, ammonium, magnesium, phosphate, they cause huge calculi, and usually you need surgery to remove them. You can't remove they don't just pass. Okay. So again, a very quick. I'm just conscious we're running out of time, so I don't want to keep you guys too late. So we're just gonna do a quick review of the renal syndromes. So what I want you guys to think about is nephrotic syndromes are problems with the podocytes. So the podocyte barrier is impaired, whereas nephritic syndromes are the more endothelial barrier. So because the endothelial barrier is in contact with the blood, you get inflammation, and that's why you get the kind of blood in the urine, whereas in nephrotic syndromes, you don't have any inflammation. So typically you don't get much blood in the urine. So the key triad to remember for nephrotic syndromes is everything with O, which kind of helps. So nephrotic has the three O's, so edema, hypoalbuminemia, and proteinuria. Um, so proteinuria is the main thing, and it's in the nephrotic range, so over 3.5 grams per day. This proteinuria can lead to the loss of antithrombin 3 and immunoglobulins, so you can become hypercoagulable, and you can become immunodeficient because you're losing all your immunoglobulins. The most common two to remember are minimal change disease, which is the most common in children, and usually there's no change on light microscopy, and membranous nephropathy, which is the most common in adults and can lead to the spike and dome appearance on light microscopy. The other types, I wouldn't say are too high yield to remember. If you have the extra brain space, then go for it. But I'd say for the purpose of the formative, at least learn minimal change disease and membranous. Again, this is just a review diagram. Nephrotic syndromes are associated with hematuria, so blood in the urine. You still get some proteinuria, but not as much as 3.5 grams per day. And most characteristically, you get high blood pressure as well. So the blood in urine and high blood pressure should point you more towards a nephrotic syndrome than a nephrotic syndrome. In terms of the most common causes, you get post-infectious glomerulonephritis, which is usually after infection with Staphylococcus. And you can get IgA nephropathy, which can also happen after infection. But the key thing to remember is that post-infectious glomerulonephritis is 1 to 3 weeks after the infection, whereas IgA nephropathy is 1 to 2 days after the infection. Um, Many of the nephritic syndromes can lead to this thing called rapidly progressive glomerulonephritis, which is quite severe glomerulonephritis of the kidneys. Um, and basically there you see crescents forming on light microscopy. And there's three different types. Again, that's very, very specific. It isn't super high yield. So if you don't want to commit that extra brain space, you don't have to for that stuff. Again, this is just a review of nephrotic versus nephritic syndrome. Tubular interstitial nephritis we covered very briefly. It can be a cause of intrarenal AKI. It's basically an inflammatory reaction in the kidney, so not in the tubule, but around the tubules. That's why it's called interstitial nephritis. And it can happen in patients that usually have just taken an NSAID. The most characteristic thing is you can see these inflammatory cells on biopsy, usually eosinophils. Um, and you don't get RBC casts. So it's not like a glomerulonephritis where you get RBC casts. So you can kind of tell the difference between glomerulonephritis and tubulointerstitial nephritis by looking for whether or not there are RBC casts. Kidney tumors, we've got three benign ones. So papillary adenoma, angiomyolipoma, and oncocytoma. I'd say oncocytoma, it's important to remember it's brown and it has a scar in the middle. Angiomyolipoma, as the name says, has three components. It's blood, muscle, and fat. Papillary adenoma kind of is the odd one out. It's well circumscribed. It's not really got anything specific about it. Renal cell carcinoma is the most common malignant tumor of the kidney. Smoking is the main risk factor, and you can also get inherited mutations. So von Hippel-Lindau can cause renal cell carcinoma. The triad you usually see is hematuria, loin pain, and a mass. So if you see someone with hematuria and pain in the loins, your differentials should be something like, could it be a renal stone or is it renal cell carcinoma? In children, you can get a Wilms tumor, so nephroblastoma, and you usually see them below 5 years old, and the survival is now very good. That's kind of the main things you have to know. You have to know you see it in kids, and it's usually quite a big abdominal mass. Um, it's also quite important to remember that the renal pelvis of the kidney, is made of transitional cell epithelium. So just like the kind of bladder cancer where you can get transitional cell carcinoma, you can get that in the renal pelvis as well, because that has transitional epithelium. So thinking of bladder cancer, most likely it's transitional cell carcinoma, or as it's also called, urothelial carcinoma. Less common is squamous cell carcinoma, and like really uncommon is adenocarcinoma. So it's usually urothelial is going to be the answer, unless they give you a specific risk factor, like something like schistosomiasis, which is associated with squamous cell carcinoma. Um, so again, yeah, urothelial is the most common. Most commonly affects males. And the high yield things to remember for it is that smoking can cause it, and aniline dye exposure can cause it as well. Just because I'm conscious of time, I'm not going to get you guys to do the question, but I will put the questions up with the recording so you guys can look at them after. Um, Squamous cell carcinoma and adenocarcinoma, as I said, squamous cell is the second most common. Um, you'll be able to recognize it because it'll have the features of squamous cell, so things like keratin pearls, intercellular bridges, same as the things you see in squamous cell carcinoma of the lung. Um, and the things that are associated with it are irritation of the bladder. So not smoking, which causes urothelial, but irritation of the bladder, specifically caused by schistosomiasis. So if you ever see schistosomiasis, think squamous cell carcinoma. This is more like an AKT thing, but I think it can come up on LabMed as well. Adenocarcinoma, really, really uncommon. The only time they'll ask you this is if they ask what is the least common type of cancer in the bladder, and the answer will be adenocarcinoma. So it will never be the answer if someone's presenting with like bladder cancer type symptoms. Okay, getting towards the end, prostate and benign prostatic hyperplasia. So the prostate gland surrounds the urethra, and it makes this thing called PSA. So the epithelium of the prostate makes PSA. That's why elevated PSA can suggest prostate cancer. The inner zone of the prostate, so literally the part just around the urethra, is what is affected in BPH. That's why you get these really bad kind of urinary symptoms, whereas carcinoma happens more on the outside of the prostate in the peripheral zone. So benign prostatic hyperplasia is basically an increase in the size of the prostate, but it's not malignant. It's thought to be to do with age, and it affects, a lot of men. The majority of almost half of men more than 65 years old will have some degree of benign prostatic hyperplasia, and it can cause these lower urinary tract symptoms. So it's difficult to start a stream, you have decreased flow, it's hard to stop the stream once you've started. Those are all symptoms of BPH. Um, Think about prostate cancer. That's the most common type of cancer in men. It has a relatively good prognosis, and one of the stats that most people talk about is that more people die with prostate cancer than of it. It's almost always an adenocarcinoma. Remember, the prostate is a gland, it's very glandular. So adenocarcinoma is very common. You will almost never see a squamous cell carcinoma of the prostate. Again, I'm pretty sure that's a question that can come up. They ask you what is least likely to be the cause of the cancer in the prostate, and squamous cell will be the answer. And again, because unlike BPH, which affects around the urethra, because prostate cancer affects the outside of the prostate gland, it can be asymptomatic. But if it gets bad or if it gets big enough, it can start affecting the urethra as well, and you can get the lower urinary tract symptoms. But most commonly, hematuria is going to be an indicator more so than the lower urinary tract symptoms. Again, important to look out for bone pain because prostate cancer very characteristically metastasizes to bone and most commonly the back. So usually you'll see back pain because there's a venous plexus that goes from the prostate to the spine. So the cancer cells can easily get to the spine and cause back pain. Usually you do an MRI to have a look at the prostate, and you can do a biopsy as well to check for the grade. Okay, testicular tumors are really annoying to learn because there's a lot of different types. Um, there's the two main distinctions, so germ cell versus sex cord stromal. So the germ cell is by far the most important to think about. The germ cells are the actual cells that are giving rise to our sperm, whereas the stromal tumors are the kind of supportive cells, so Leydig cells, Sertoli cells. There are a few markers that can go up, so beta HCG, AFP, and LDH. Beta HCG being most associated with choriocarcinoma, but can also be associated with seminomas. AFP most characteristically in yolk sac tumor and also hepatocellular carcinoma. So that's one thing to keep in mind. And LDH is usually associated with how bad the tumor is, because LDH is released when cells die. So the more cells dying, the more LDH you release. So because most testicular tumors are germ cell, let's focus on those. They're separated into seminoma and non-seminoma. Seminomas are the most common. They affect men in kind of relatively early life, so between 20 to 50 is the most common. In their 40, a 40-year-old man would be the kind of most common age you'll see testicular tumors in. and they can spread via the lymphatics. Non-seminomas affect typically younger people than seminomas. And that's kind of your yolk sac tumor, your choriocarcinoma, your embryonal carcinoma, your teratoma. And they spread hematogenously. So that's kind of one thing to remember. Remember, seminoma, older people, lymphatic spread. Non-seminoma, younger people, hematogenous spread. It can be useful to learn the different types of non-seminoma and the markers that go up in them, but I wouldn't worry too much about the kind of exact histology of each. In terms of the risk factors of testicular cancer, one of the main ones is cryptorchidism, so undescended testis. And the reason for that is because the testes need to be in a colder environment to work well. So if you have an undescended testis and it's up in your abdomen somewhere and it's at 37 degrees rather than 32 degrees, there is going to be some abnormal growth in the testis and you are at higher risk of cancer. Okay. All right. That is the end of the revision session. I hope you guys found it useful. If you could please scan the QR code and leave some feedback, that would be much, much appreciated. Um, I wish you guys the best of luck for your formative. I'm sure you guys will do fine. Again, I'd say this was quite like a overarching review. So try to just go through the main kind of core things without delving, getting too stuck in the nitty gritty, especially at this stage. You'll have loads of time before the actual exam to learn all the small details. As long as you're kind of good on the main ideas, I'm sure you guys will be fine. Anyway, I'll let you guys go. Have a good evening and good luck.